Welcome to this complete guide on regurgitation in pediatrics, distinguishing it from vomiting. This video covers essential concepts for nursing and medical exams. Regurgitation is defined as the passive, effortless return of gastric contents into the pharynx or mouth. It is commonly known as spitting up or posseting. It is typically physiological and resolves spontaneously between 12 to 18 months of age. Let's compare regurgitation and vomiting. Regurgitation occurs primarily due to an immature lower esophageal sphincter, or LES, the muscle ring between the esophagus and stomach. When the LES relaxes inappropriately, milk flows back up. Other contributing factors include a liquid diet, the infant's horizontal position, and a short esophagus. The happy spitter is an infant who spits up frequently but gains weight normally and is generally comfortable. No medication is usually needed for this condition. Regurgitation is passive and effortless. The primary anatomical cause in infants is an immature LES, which usually resolves by 12 to 18 months of age. Gastroesophageal reflux, or GER, becomes GERD, gastroesophageal reflux disease, when it causes complications. Symptoms in infants include failure to thrive, excessive crying, arching of the back, and refusal to feed. In children, symptoms include heartburn, abdominal pain, and chronic cough. Sandifer syndrome is a neurobehavioral manifestation of GERD, characterized by reflux, spasmodic torticollis, and dystonic body movements, often mimicking seizures. Diagnosis often starts with history and physical exams. The gold standard test is 24-hour pH monitoring. Barium swallow rules out anatomical defects and endoscopy checks for esophagitis. Conservative management, the first line of defense, involves positioning the infant upright for 30 minutes after feeds and frequent burping. Dietary changes include small, frequent feeds and thickened feeds, such as adding rice cereal to formula to help keep the contents down. Pharmacological management involves using medications to address GERD when conservative measures are insufficient. Severe GERD may require surgical management. The procedure of choice is Nissen fundoplication, where the stomach is wrapped around the lower esophagus to tighten the sphincter. The gold standard for diagnosing GERD is 24-hour pH monitoring, as it is the most specific and sensitive test to quantify acid reflux episodes. Hypertrophic pyloric stenosis, or HPS, is a surgical emergency caused by the thickening of the pylorus muscle, obstructing the gastric outlet. The key difference from regurgitation is that vomiting in HPS is projectile and forceful, unlike passive regurgitation. Classic signs of HPS include projectile, non-bilious vomiting, a palpable olive-shaped mass in the right upper quadrant, visible peristalsis, and the infant being hungry immediately after vomiting. The triad of projectile vomiting, non-bilious vomitis, and an olive-shaped mass is classic for hypertrophic pyloric stenosis. Complications of severe regurgitation or vomiting include aspiration pneumonia, failure to thrive due to nutrient loss, and electrolyte imbalance, potentially leading to metabolic alkalosis and dehydration. Common nursing diagnoses include risk for aspiration, imbalanced nutrition, deficient fluid volume, and parental anxiety. To prevent aspiration, keep the infant upright for 30 minutes after feeds and handle them gently. Frequent burping is essential to reduce air swallowing. The best position for a child with GERD after feeding is upright. Pyloric stenosis requires Ramstedt's pyloromyotomy surgery, while GERD may require Nissen fundoplication. Red flags indicating that it is not simple physiological regurgitation include bilious or projectile vomiting, blood in the vomit, onset after 6 months of age, failure to thrive, or abdominal distension. Persistent vomiting leads to metabolic alkalosis because the loss of gastric acid results in a loss of hydrogen ions. Parent education involves reassurance, avoiding overfeeding, and considering thickened feeds. Avoid exposing the infant to tobacco smoke, as it relaxes the LES. Related conditions include hiatal hernia, a protrusion of the stomach, and rumination disorder, which involves repeated regurgitation and rechewing of food.